Good evening, everyone. I, Dr. Anjana Talukdar, on behalf of Pratiksha Academy, welcome one and all. Today, the topic of the discussion is Universal Newborn Hearing Screening. The speaker is Pragya Bharadwaj. She is CEO and Interventional Audiologist at Pratidhwani Clinic. Moderator is Dr. Ashok Kumar Biswas. Sir is Senior Professor of Department of Speech and Audiology, Guwahati Medical College. Over to you, sir. Biswas, sir.
Good evening.
Good evening, sir.
Good evening.
Good evening, sir.
Let us start the topic today. Today, Pragya is going to present either UNHS or NBHS. Before we start the program, let us say a few words about UNHS or NBHS, how it started. It started in 1969, basically. Main person was Marion Downs. She was an audiologist, and she has some like-minded person with her who are basically from American Academy of Pediatrics, American Academy of Otology and Ophthalmology, and American Speech and Hearing Association. And they felt that hearing screening should be done for the children, and they started a multidisciplinary committee. But when they met, they called them as a joint committee of infant hearing. But initially, they never thought that after 50 years, that will become a gold standard. Then Downs started a project in Denver that is known as Denver Project, and she worked for 2 years with the children, and she presented her paper on 1971 in presence of the committee. But the committee applauded her presentation, but they never accepted the recommendation. So it was discarded, and 1973, they met again, and the committee said though that universal neonatal hearing screen is not possible, and they thought that it will be a high-risk register that should be maintained. Okay, and they gave 5-level risk factor. The first one was family history of hearing loss. Then second was intrauterine fetal infections. And third was defects of the ear, nose, and throat. And fourth was low birth weight. And fifth was high bilirubemia. So they thought that if these 5 criteria are there, then the child should be screened. Then by this time, high-risk register was quite popular, and Joint Committee met in 1982, 1990, 1994, 2002, 2007, 2013, and 2019. But the turning point was in 1990s, actually, when a project was known as Rhode Island Project. And here they screened around 70,000 children. And they found out that 50% of these high-risk children, they are missed by the hearing screening. And by the same time, this special meeting was done. And in 1994, universal neonatal hearing screening was implemented. And they have said that initial criteria was 136. That by first month, every child should be screened. By 3 months, it should be confirmed. And by 6 months, rehabilitation should be started. But recent recommendation is 1, 2, 3. That first month, it should be screened. Second month, it should be confirmed. But by third month, your rehabilitation should start. So this is the basics of NBHS or UNHS. Now the Pragya will present detail, and she will tell us in detail. Thank you. Over to Pragya.
Thank you, Biswas sir, for very smoothly sliding us into the topic. Thank you, Anjana ma'am, for giving me the platform today to speak on this topic. Just give me one moment to share my screen. Is my screen visible to everyone?
Yes. Yes.
So universal newborn hearing screening, this topic may sound a little bit repetitive maybe for a lot of us, because I think we have had discussions on this earlier also. So today I will try to limit my talk on the information that we probably already have discussed in the past, and try to discuss more on what we have learned more recently, and maybe discuss more on how or what can be done to actually implement newborn hearing screening in our state or in our region. So contradictingly, I'm going to start my talk with a few redundant numbers, a few redundant information. Redundant mostly because most of these numbers are quite old, these figures. So talking about prevalence of hearing loss in India and in Assam, NSSO's 2002 report told us that around 2.91% of the population suffers from disabling hearing loss. So the word disabling is crucial here. WHO's 2018 report estimated around 4 in every 1,000 children being born with severe to profound hearing loss. And coming to Assam, the last report that we have is from Vani in 2011, where they reported around 50,000 individuals in the population suffering from hearing loss. Now, I think all of us can imagine that most of these numbers are in all probability underestimations of the actual prevalence, with the number of non-institutional deliveries, with the lack of a proper screening system in place. A lot of the children, a lot of individuals are missed out, and there is no statistical report on incidence and prevalence of hearing loss in this region for more than 10 years now. Impact of hearing loss, we all know that there's a functional impact where hearing loss directly limits a person's communication ability. In case of children, it limits their speech and language development. But it also, more than that, it also affects the person's ability to integrate themselves in the society, in the mainstream society. And that in turn has an emotional impact. Their emotional development, their emotional well-being is usually affected by their inability to blend in the society. And the rate of enrollment, and especially the rate of retention of a hearing impaired child in schools, is much lower than 39% as per Vani's 2011 report. So the literacy rate is very low, and therefore the economic opportunities for these individuals are very much limited. So there's definitely huge economic impact, and this is not just on the individual or that individual's family, but on the whole society. So WHO's 2020 report reported the global economic burden of unaddressed hearing loss to be around 980 billion US dollars. And 57% of that is attributed to low and mid-income countries like that of us. So causes of hearing loss, I'm not going to go into details. I'm sure all of us are more than familiar with the causes of hearing loss. The figure that I have put up here is sourced from a number of studies. So there will be a few variations here and there, but what I want to draw everyone's attention to, and what is commonly stated in across different studies, is that a majority, 60%, in some studies even report 70% of the hearing loss has a genetic link, and 70% of them are non-syndromic, mostly having autosomal recessive inheritance pattern, and sometimes even linked to a single gene mutation. So these are the individuals who do not have any evident risk factors, any family history, and hence are most likely to be missed out or not suspected to have hearing loss. So with all the noise that has been going on around newborn hearing screening, many of the centers have implemented newborn hearing screening, which is a good news, but most of them are restricted to high-risk hearing screening. So with high-risk hearing screening, we are screening in babies who have an evident one or more high-risk factor. So with this, we are able to cover one portion of the individuals, but a huge chunk, more than 50% of the cases with autosomal recessive inheritance with a non-syndromic genetic hearing loss are getting missed out with high-risk hearing screening. The only way we can hope to cover all of them is through universal newborn hearing screening. So universal meaning each and every newborn being born needs to be screened for hearing loss. When can we start screening? As soon as 24 hours after birth. But there are studies which report that a duration of around 48 hours after birth gives a more reliable test result. So anyway, between 24 to 48 hours after birth. What are the tools that we have for screening? Most of the centers use the autoacoustic emissions, OAEs, a combination of OAEs and the auditory brainstem response, that is ABR or the BERA test, for a two-stage hearing screening program. The program, the action flow is somewhat around like this. There may be a few tweaks here and there from center to center, but mostly it looks like this. Many of the Western countries and some of the large centers, even in our country, are using automated ABR for screening. So that is a screening tool which measures the fifth peak of ABR at a single intensity, mostly the 35 dB at 35 dB NHL for newborn hearing screening. If we compare the autoacoustic emissions versus automated ABR as the first stage of screening, both has its advantages and maybe some disadvantages. So the referral rate, the false positive rate is much higher in autoacoustic emissions or OAEs compared to AABRs. The sensitivity in detecting sensory neural hearing loss is almost comparable for both of the tests, but automated ABR has the advantage of being able to identify auditory neuropathy spectrum disorder, which are always missed out through OAE screenings. The test time is much lesser in OAEs. It's on an average, it takes about 3 to 5 minutes per baby, whereas for automated ABR, it can take anywhere between 11 to 13 or 15 minutes for each baby. The cost of equipment, again, for OAE is lesser compared to automated ABR. But if we think about a large, high volume center, if you think about the time factor, OAEs has its advantages. However, if we also think about not giving or limiting the false positive findings, then AABR has a huge advantage. I think recently Guwahati Medical College has implemented the automated ABR for their hearing screening program. We don't have information about it yet, but hopefully we'll learn how's their experience been so far soon enough. So again, why this early? We all know, I think we have talked about it. It's because when we talk about hearing loss, it's not really about just the ears. We have to think about the brain, especially when we talk about hearing loss in children. It is not just affecting a child's ability to hear, but it is affecting a child's ability to develop communication skills. It's affecting their social skills, their academic skills, a whole lot of avenue. It is restricting basically their brain growth. We all have learned about multiple studies. It is an established fact now that there is a significant link between identifying hearing loss before 6 months of age or starting intervention before 6 months of age and getting good speech and language outcomes by 3 years of age. It's because of the rapid growth of neural connections in the brain within the first 3 years of maturation. So this figure, which is adapted from a very old Cornell paper, what is interesting over here is to see the growth or the increase in the neural connections, exponential growth in the neural connections in the newborn's brain within the first 6 months. The more recent studies which talk about sensitive periods of human development, which are basically intervals of growth where the brain is more sensitive to a particular stimulus or a particular sense. So here in this figure, if we look at the maroon line, it represents the sensitive period for sensory pathways like that of vision and hearing. So here we can see that it reaches its peak. The brain is the most sensitive to auditory stimulus within the first 3 months, and after which it doesn't mean that the brain stops hearing or stops developing listening skills. It's just that more of the neural connections or more of the brain's energy is directed towards focusing on sounds and visual stimulus, which in turn triggers the rapid neural maturation in these regions of the brain. So with this recent findings, like Biswas just mentioned, there has been changes brought about in the global policies also. We all know about the Joint Committee for Infant Hearing Screening, JSEIH, and up till 2013, their position statement recommended the 136 principle, which was updated by their 2019 position statement. It was updated to 123 principle. So screening of every newborn by first month of age, diagnosis within second month of birth, and intervention beginning at 3 months of age. And this is not just on papers. This is not just a recommendation on papers. There are, in developed nations, this is already in practice. Children are getting fitted with hearing aids as early as 3 months, and many of them are getting, whoever needs a cochlear implant are getting cochlear implant within their first birthday, and they are on the listening and learning pathway already by their first birthday. We, Indian Academy of Pediatrics also came up with a consensus statement in 2018, which followed the earlier JCH recommendation of screening within first month, diagnosis within third month, and intervention of hearing loss within 6 months of age. So this is a good news. We have a consensus in our hand, but how much of it are we able to utilize? So unfortunately, or fortunately, actually, at least the state of Kerala has been able to implement statewide newborn hearing, universal newborn hearing policy, screening policy. And today I thought let's went into their program quite a bit to try and learn from their program what it is that we can take away and what it is that we can implement. So their newborn hearing screening program is part of the comprehensive newborn screening program, the Shalabam program. And the motto, I put up the motto also, it's a life-saving innovation with country-wide relevance to improve quality of survival. So I think I really like the term quality of survival. Most of the times in our country, we are still talking more about the rate of survival, the rate of survival basically, but not really on the quality of survival. I think if we start focusing on that part, it becomes very clear why we need the newborn hearing screening program. So how they are doing it, the course of screening is somewhat like this. And the OE screenings are carried out around 48 hours, which is carried out by trained nurses in each of the delivery centers at state, at district levels. And the referred cases are then followed up at district early intervention centers or empanel public or private sector hospitals or centers. So in terms of coordination among human resources, it's mainly headed by the state health ministry and the national health mission. Under them, there are RBSK coordinators who are assigned for this task. And then again, at district level, there at each district, there is a district DEIC or district early intervention center managers. So at this level, they are responsible for basically manpower training up nurses and technicians to carry out the newborn hearing, the first step of the newborn hearing screening, monitoring the databases, updating databases, and then coordinating between the delivery centers and the referral centers or the empaneled private and public and private sector hospitals. One very important thing, even in the JCIH position statements also, what they focus on, apart from the timing of screening, they also focus on the management of database. I think all of us who are running a newborn hearing or has some experience with newborn hearing screening, we all have faced the problem of we all cross the first screening, but then the follow-up rates are very low. And so the database management is a huge issue. So in Kerala, what they're doing is the flow of action is somewhat like this. The screening is carried out at the public sector delivery points. The data is immediately uploaded in a central universal hearing screening server against a unique ID assigned to each newborn. So it is updated to in a central database. It's a simple server where the trained individual can log in and enter the infant's data. This data is then reviewed by the experts at DEIC centers and then color coded depending on its status, whether the child has passed the screening, whether it needs to be followed up by experts, whether experts have seen and the child is diagnosed with hearing loss, and so on and so forth. The refer babies are referred to the DEICs. There are both public sector and private sector hospitals empaneled to provide the further expert diagnosis and intervention. And this data, from the universal hearing screening server, is then uploaded to a larger web portal known as the Jatak Seva web portal. So the database is basically maintained centrally and digitally. So that is a huge advantage which helps people to know the data against each newborn individual, what is the status, and then to follow up. So this is what if anyone wants to go to the server, we can take a look at the Jatak Seva portal, and the data is mentioned over here. So these are some of the key things that I have taken away, and what are the things that I thought we could learn from it, or what really struck me is one thing that we need very urgently is trained manpower. So trained manpower, I'm not really talking about ENTs and pediatricians or audiologists directly, but efficient enough individuals, nurses and other technicians who can be trained to carry out this program. We have centers, we have assigned centers at district levels. Even under NPPCD, there are centers across all districts and regions. But how well equipped are they to really diagnose a child, or to counsel a family regarding what needs to be done, or to coordinate amongst the care centers and the delivery points? So equipping the tertiary centers and the DEICs, having a central database registry is very, very important, I think, if we want to carry out a large volume or universal screening program statewide. And definitely with the volume of the population that we have, with the volume of deliveries that we have, if we only depend on public sector centers, hospitals, it's not possible for them to address this huge volume. It is just near impossible. So it is important to have a coordination between public health sector as well as among private centers, and work together. And we can learn from the EDIT cochlear implant program, which is running very successfully in the country, and they have empaneled both public sector and private sector, which are eligible enough, who has the infrastructure, who has the manpower to provide the services. And then another most important thing is that this voice should not only be coming from audiologists, from ENT specialists. It has to be, the drive has to come from the first professionals who see a newborn. It has to come from gynecologists, from the neonatologists and pediatricians. So they have to be on the board, they have to be vocal about it, and only then I think we can hope to really implement it. So some of the challenges, again, maybe not very specific to our region, but some of the challenges that I could think is the number of non-institutional deliveries. I think non-institutional deliveries overall in the entire country is quite high, but we believe the numbers compared to Kerala, the numbers may be much higher in our state. Definitely inadequate infrastructures in district centers and tertiary centers is an issue. And the lack of trained manpower, not just lack of trained manpower at the screening level, but also the professional professionals to train these manpower. The ratio of an ENT doctor to the population with hearing loss is already very skewed, and if we talk about audiologists, it's even worse. So who's there to take up the onus of training these individuals and to monitor their work? So that is one of the things. We know that South Indian states like that of Kerala, Tamil Nadu, Karnataka, they have a lot of institutions. They have a lot of institutions who are providing the course of audiologists and speech language pathologists. They have the volume of doctors also slightly higher. So they have that advantage compared to our area, although we are also coming up with CRCs, the BASLP program, the graduate program for speech and hearing that was run by CRC has already given us a number of young professionals. So that is an advantage, and we hope if we can have more institutes in our region, if we can generate more professionals and not depend on other manpowers, I think that can be a big help. The referral centers, definitely we have inadequate referral centers. And again, like I said in the previous slide, we have to have a coordination among private and public sector hospitals in order to carry out a screening program successfully. Transportation to referral centers, since we have inadequate referral centers, even if a baby is detected with hearing loss somewhere or suspected, they have to travel a long distance to come to a referral center. And there a lot of things come into place, the conditions of the road, the natural calamities, all of that. So transportation also becomes a big hassle. So again, having more centers, more locally, and having more well-equipped centers at district levels and locally would definitely be a help. So coming back to the need, again, I think it's well established. So considering if early identification is resulting in early intervention, it can definitely result in significantly higher return on investment, not just for that family again, but for the entire community, but even for the government bodies who are providing services. So with this same cost of device that we are providing a child who's who starts hearing earlier, because of their neural cortical plasticity, they would require lesser frequency and shorter durations of auditory rehabilitation sessions, and that in itself can relieve the financial burden in a huge way. The cost of traveling, especially for the long distance patients, the cost of uprooting their life and then living in a different city temporarily, coming and going to the center every day, a lot of the things. These are invisible and inevitable costs which is involved in the process. And again, as already established, implanting or starting the hearing process intervention at an earlier stage can result in better speech and language outcomes with the same device of the same cost. With better speech and language outcomes, with lesser cognitive load, the chances of realizing better academic and employment potentials is much higher. Also, the acceptability and efficient utilization of device is higher when the outcomes are better. So, like I said, with the same cost of device, a child who is implanted earlier will result in a much higher return on investment for all of us. So with newborn hearing screening, early identification of hearing impairment resulting in early intervention, resulting in productive inclusion of an individual in the mainstream society. That is what we are looking for. And again, let's remember the term quality of survival to advocate for universal newborn hearing screening. So that's all I am going to talk about. We can, I think, discuss further on this. Thank you.
Thank you, Pragya. Now we can have some question.
One can unmute and speak. Pragya, you close your slide.
Yeah.
Pragya, thank you for a very detailed talk, a very exhaustive, in fact. And there's a small point I would like to make. You talked about the time taken for OA screening. I think you can add your 2-3 minutes of OA screening in ideal conditions, because if the conditions are not ideal, I think to get a correct OA response would take much more time than 2-3 minutes.
Yeah, so this is an ideal condition, definitely. If it's a silent room, if the baby's sleeping or at least in a resting condition, no respiratory distress, then we can expect it to be a 3 to 5 seconds.
Yeah,
Again,
because
because
when we are
it's
talking about screening, you may not be doing it in your perfectly conditioned audiology room. You will be doing in an ICU setup. So, I mean, you had this trouble in the international hospital, Apollo Hospital, all the time
true,
of
true.
not getting a proper soundless environment.
Yeah, that's true, sir. These information are collected from Western sources who have the infrastructure and the ideal conditions, hence the figures look like that. In our condition, I think, yeah, definitely good point, sir. It takes longer. And in such situations, I would like to add automated ABR, since it's less affected by noise, becomes a better option actually. May take almost the same or just very minimally longer time.
But the cost is a problem there. Okay.
Yes, definitely. The cost is much higher for a automated ABR compared to an OE device.
Guwahati Medical College has started with Bani in the gynae department. They have started this program and they are doing screening. Every day they are doing 7 to 8 screening, and their outcomes are good. Whatever I have found, their outcomes are good. And when they're getting a abnormal response, they're sending it to us for your diagnostic ABS and all. And we do perform the diagnostic ABS there.
Right. So I think I was hoping to get more insight on what has been the experience in Guwahati Medical College. So I believe the false positives, the rate of false positive would be much lower.
Yeah, what I observed, they have referred us few cases and rates are less. Yeah, few cases are negative, but rates are less.
And the problem is not with the false positives. The false positives will be screened and you can rule out. But it is the problem with the false negatives. You say the child doesn't have a problem where the child is having a problem. So when you're testing, actually, it's the false negatives which are much more important.
Correct.
Good evening. Can I add, Pagya?
Sure, sir.
It's your nice talk, mostly kind of an administrative talk rather than your clinical talks, as we have seen in regular platform. Anyway, very conclusive talk from administrative point of view. But Biswas sir, sorry to directly the questions. Can I give you the term what we are doing now as a universal newborn screening? What we are doing in Guwahati Medical College? What we are doing in our
This
study?
is basically whatever we are doing is basically high risk infants. This is basically high risk infants.
Why not, sir? Then
He is not there. So much cases are there.
That is
look, sir, it's a high time that we have a webinar, we have a presentation, we have everything. But if you can't do, then why you talk all in this topic then?
You have put the topic, you have Pratiksha Academy people.
That's why I'm coming for the discussion.
What I'm telling you, down the line, do you remember down the line 10 years back?
Yeah.
There was nothing. Okay. Now, after 10 years, slowly, yes, we started. Yes. Initially, there was no ABR. Whatever ABR was, that there was not, they were not appropriate. They could not give appropriate results. Then we started with ABR. Now they are giving good results. Okay. Now slowly, see, things are not very fast because our administrators do not understand all these things. No, we are the clinicians. No, we can tell, but the administrator has to put it on things, no? So things are moving. I do not know how much time it will take, but it is going. It's not that it is everything has been stopped.
No, sir. If you see this Pragya presentation, this Kerala program, they have that is not a big thing. I think if they have a software like a COVID kind of thing, that these are the positive cases, these are negative cases, and they have given a unique number of every child born after delivery. That's all. That they have to fast forward a OE program by any institute who is delivered institutional wise, and they have the follow-up program. That's all, sir. So, but at this 2020, why you can't have a legging of this kind of program now? That's why because in that way, look, sir, we are doing a deep cochlear implant. Ultimately, why we are talking all these things? Because of the early intervention. Now we have seen the results of who have implanted after 3 years. You go with a hearing aid, with a hearing loss child after 3 years or cochlear implant, we are not getting that much of results, sir. We should be truthful ourselves. So in that sense, we needed the high time to have a practical oriented some program in our state. And I request Vishwas, sir, because you are also detrimental in our program also in Pratiksha. You have installed all our OE machine, Bera, then we have processed all this struggle. But I think we can start. That's why I am putting this is the same topic of universal yes can still exist the topic, and hopefully I am hopeful also, sir. Since Vishwas sir is here, he's in a epitome of this institute. So we should start nowadays audiology. If you see that there's audiologists are coming, new audiologists coming, the guidelines is already there. How to do it's different thing. Guidelines is now coming with a 1, 2, 3. Not we have a few months back we have a meeting that how to incorporate from 136 to 123. Then we have found ourselves it's lots of issues are there. Nobody is interested to come to review for to do Bera in. I personally asked Mansi Razina, are you sure you are going for Bera in 2 months? Can you say 100% that this child has a hearing loss? Because your two guidelines, that guideline is not what is the less adopted by the Indian Association of Pediatrics, who is here?
2018.
2018. Look, but I asked Mansi and Rosina, not Pagya, can you say the 1-3 guideline on the month of 2 months? Can you say this child has a hearing loss at the month of 2 years? So this question I today put to Pagya also.
So it will depend on the child. If the child is a high-risk baby, if it's a preterm baby, then we definitely need to be cautious. We cannot really diagnose a baby with hearing loss at 2 months. When we say preterm also, we have to consider how early or how much, preterm by how much. But theoretically also, and from what we have seen also, if it's a healthy baby born at term, and so in these children, if they have good hearing, if they if they have normal hearing, we get good enough responses by 2 months. We have got by 2 months, but like I said, we have to consider if it is a child with global developmental delay, if the child is preterm, low birth weight, all those risk factors have to be taken into account.
Pragya, if I may add to what you actually said. So yes, just like Viswada just now said that we had a meeting. See, in Pratiksha, thanks to a very active pediatrics team and a very active ENT team, we are doing a very high volume newborn hearing screening at Pratiksha. So even then, although we have a full-time junior resident only for the newborn hearing screening program. And he even follows up for, calling up patients to come for Bera after 3 months. Even then, the follow-up rates are very, very less at the age of 3 months. Because the main concern, when we ask the parents, the main concern is definitely sedation. So if the parents are concerned about sedation at 3 months, what about sedation at 2 months? Where if we follow the recent guidelines of 2019, then we have to go for a diagnostic Bera at 2 months. So that's a major challenge that we faced, And even when the pediatricians were consulted, they were a little apprehensive about sedation at 2 months of age. So these are actually the practical problems that we face. In addition to the clinical abnormalities or clinical complications that the baby might have.
Hello.
Yes, Furqan, sir.
Can I speak a few lines?
Yes, sir.
Hello.
Yes, yes. Mashallah,
sir.
yes.
Actually, see, বিশ্বাস, first you have mentioned the year 1969, no? Actually,
Yeah.
that audiologist is 1964, I think. He started a program. Actually, I forgot, 64 or something like that. Yes. Actually, you are talking at a high level, not institutional level. You have not gone to your village. I have done many things for 2007. I think Bishas will know. So much difference. Your Bani report is 50,000. This is 5 lakhs, not 50,000. Okay.
Not 5 lakhs, mashallah. I say it's more than that.
10 lakhs. Yes. I am very particular on that. See, you cannot resist. We may talk many things at the level, automated ABR, everything. But it is difficult. We is telling that Kerala program. Kerala, they've completely developed state. That's a different issue. Then only the software will not do. See, in the NPPC program, starting from the noisemaker, everything. You have to know everything. Distract non-trace, play audiometry, visual, everything you have to know. Startle reflex. That only can, you have to train the grassroots level, teachers, parents, and everyone. They are the main guide to diagnose the early, because nowadays they are converting to institutional delivery. But still, in some areas, you don't know, in some areas, maximum delivery is in the home delivery. Why right? If there is institutional delivery also, where there is OE? Actually, see, suppose you have put the automated ABR in gynae department. Actually, OE or this thing done for what 72 hours or 48 hours. If a canal may be blocked or something may be there is not, the report may not be correct. Still, if it is confusing, it's sent to the audiologist, it's okay. But main is the bottleneck between the government and this schemes and programs. Many huge money is there still in the government sector, but not properly utilized, because there are great bottleneck. They do not think that this subject of hearing is important. They are now thinking good, but I have left for after 3 years for this reason, because when I go to someone, they will, hey, what is your subject? They will that is not the way actually. But you cannot, this for implementation of this program, it is not easy, because you have to be gone to grassroots level, and the bottleneck between the government, top officials, fund of NHM, everything has to be equalized. There has to be decentralized. There is no decentralization. For making the fund, I have to run 10 days, 15 days. We well equipped for the MMC hospital, Nalbari hospital, and Tezpur hospital. For 3 years it took for giving a OE and some microscope and some instruments and the audiometric room with soundproof. As Pragya mentioned, OE should be done. Gautam has mentioned OE should be done in a soundproof room. Where do you get also a soundproof room? It's difficult, actually, very difficult. Actually, but on suspicion, you have to send. But people are so poor here, they cannot come to the purpose to take the advantage.
Sir,
That is the main problem.
Furqan,
At the level you can go. Those
Furqan,
who have
sir.
got money, you can do ADP scheme, Sneha's worker scheme. That's okay. But how much cochlear implant or do you give rehabilitation? How much hearing aid? See, once I've done, I gave research, there's 3 types of hearing aid they have given. For a more hearing loss, middle, and when the Pragya and other only natural speech and hearing, that South fellow, they are very intelligent. They told me, sir, don't give this hearing aid. They will cause more deaf to the child. What to do? Government has lagado. Or this is the given supplied from the Delhi. There is not the thing actually. Someone has to see. It's not easy. Only few cases you can.
Mashallah, do you remember there is a complaint also, no?
Yes,
There
complaint
is
also.
one main
And
complaint also.
I've been asked from Delhi, why you have not distributed a hearing aid? But you come and distribute a hearing. I will not do. I am very bold on that line. You do and I will not do. I will explain. You come. Narang or someone was there. I don't know. Because he has done with the help stadium. That is not the way.
Anup Narang, yes.
No,
Sir,
Biswas sir, I'm concerned now, but the government is little bit of interested now.
Interest is already
no, because they have
20 years gone.
they have already given the OE, according the information.
No, you don't know
They have already given OE and Bera, I think, in the civil hospital also. Biswas sir, am I right?
That I have implemented. Who will
That
do?
is
No, they very
Business
very
is very right.
Sir,
Universal
Sir.
program you cannot do here in Assam.
That's why,
Not
sir,
easy.
I am telling you.
Only the high risk group you can do. We
And
have
that's
done
why
even paper also on high risk group.
Sir, that's
They
why I'm
publish paper
interested,
also.
since people like a Biswas sir is there. Biswas sir is there.
What he can do alone?
Ah,
What he can do alone?
but who will do that then, sir? Because
I
our soils are suffering, sir. If you know,
Sir,
That we all know.
who will do? If you sir say that all our patients are going to Chennai and Delhi,
No, go,
if
we'll go.
nobody is doing, sir. So every hour
Still
then
go.
in this subject, we are in the ENT hearing is the basic. Then if you don't do, if you're not serious, that's why I'm requesting. This is my humble request to Biswas
No,
sir.
that is the there is a responsibility of not the ENT audiologist, responsibility of the gynecologist, pediatrician,
Very true.
neonatologist, every
That's true, sir.
principal of
That's
the
true.
medical
Exactly,
college,
sir.
the
That's
director
true,
of
sir.
medical education, minister, health minister, everything has to have to do that. Otherwise, you cannot do. I'll tell. I'm 4 or 5 years I've done as a state nodal officer. What can I do?
Sir,
You
that
cannot
is a
do.
problem nowadays because we are getting so with a hearing loss side
No,
with a
no.
3 or
It's
4
easy to
years.
tell from a platform, but
Ah.
not you cannot implement.
Can I say a few
Yes,
words?
you go to mute.
I agree with Phukan sir 100% because he has seen practically the difficulties at the grassroots level and the I mean not in the medical college level, in the civil hospital levels what happens. So you are also right that now many things have come because when Marshalda started implementing the national program, at that time he had to start off with otoscopes. Forget about, I mean, having a Bera or OE. But when we talk about the Kerala example, the Kerala is not called the most literate state. Maybe Mizoram is competing with Kerala for nothing. Even if you look at palliative care, in palliative care, the society in Kerala has been so much tuned that the palliative care workers are not just the trainees from the medical colleges. They have got the society helping in palliative care. If there is a cancer patient in a village, the whole village, starting from the schoolmaster to the, the women in the house, they all come together. So actually, if you just read up about the palliative care facilities in the community involvement in Kerala, it's amazing. It does not need money. It needs involvement. It needs awareness.
Yes.
With that
Mean
awareness
involvement.
and involvement actually is the most important thing, which will take some time because our society you cannot compare with Kerala.
You
Kerala
cannot
example
compare.
is totally different.
Sir,
That's
can I
my
just add?
personal feeling.
Can I just add something?
Manas, Mansi, 1 minute.
Yes.
Myself and Marshalda has seen from the ground level how we work, no? From the
Yes,
very
yes.
beginning, how we work. It
Very
was so
difficult.
difficult to work, so difficult
It's
to
easy
work.
to tell
And,
that Bushas will do everything.
I'll tell you in
I know.
today's scenario, in our OPD, we get around 20 CBR per day.
Yes.
It is very difficult to manage
Difficult.
20 ABR per day because once the child doesn't get sedated, once the child start crying, parents say, I am from very far distance, please do me today. Okay, so much problem is there, It's so much problem we have to face every day.
Yes.
So it's very
It's
difficult.
risky also. Giving sedation and everything. Not easy.
And giving a report and tomorrow it will be a false negative, false positive, Many things have to be kept in mind, Somebody
Yes.
will say, hey, medical college is doing like this.
Like
And
this.
they do not see how many patient loads.
But if Biswasap, if actually looking at what problems you face, maybe if the private and the public sit together, try to devise something in
That is the
our
very much.
in our
Very, very much.
scenario. in our scenario, it will make a lot of big difference actually.
Very difference.
Yeah,
It will make a difference. But
maybe
but, you know,
maybe under your audiology, some audiology forum or whatever, if you can give a proposal to the government that this is something
Yes,
we
one
recommend,
forum has
I
to be
think that
managed. Yes.
might be effective.
That's why what I am requesting Vestali Biswas sir. Actually, what he is,
Yeah.
I definitely,
Yeah.
sir, definitely the struggle you are facing in your department. I know. It's
I
difficult to
suffered.
explain.
I suffered. You
No,
tell
no,
me.
look,
You
that
tell
the government is same time is not seeing that they are not giving any post for the audiologists also, no?
Right.
That is
Yes,
that because
they are
they're not concerned about all these problems actually. But,
because MCN guidelines doesn't say.
Besides,
Yeah.
I think they have not attended the disability board. Disability board on hearing, so much patient, which one is MR, which one is cerebral palsy. We have faced that one, no?
And today, one, you know,
For 6 hours, 7 hours.
today, one patient came
Yes,
who is mental retardation,
yes.
diagnosed to be 100% hearing impaired. You know,
Hearing, that's
hearing
very
is
correct.
normal.
You are.
Hearing is normal, and he has been given 100% disabled hearing impaired.
Yes.
But the child is you're mentally challenged.
And giving a report of MR, you have for clinical psychologist, so much difficult to get a clinical at that time, my time. I search and search everywhere. I call them, I request them, because there is no government incentive to pay something to them to give a MR report of grade 1, 2, 3, 4. Then how can you do? See, which one is MR, which one is there? And psychiatrist will say, sit, then he will say that, no, I am not the person. You make it as a hearing disability. Are, how can I make it a hearing disability? I cannot do that. Then because
Marshall, another problem here arises now that speech and language impairment, no, certification of speech and language impairment, and
yes.
you know, from all over Assam it sends to Guwahati Medical College. Please do the assessment.
Nowadays very difficult.
How many Guwahati Medical
All
College?
MMC is closed. All patients gone to Guwahati Medical College.
And even from the other
I
part
have
also.
heard that
No,
one. I have heard now. Someone told me that it's very difficult now.
Cleft of the palate, you know, aphasia,
Yes.
laryngeectomy, this patient can give a certification. You have to
How
assess
many
and give
cases?
the
Yes.
certification.
Very difficult.
So
You
how
have to work from morning 6 a.m. to night 12
how
midnight.
AK Biswas will do everything? I don't
Yes,
understand.
Sir, if I may add something. So I think
Yes, yes.
even if we look back to 5 years down the line, there were definitely a dearth of professionals. And of late, what we have seen is that things are getting positive in the sense that, you know, even the BSLPs who are passing out from CRC, they are getting you know, jobs in the civil hospitals in various districts of Assam. And but you know, this is very important that we get more and more audiologists, because it is very disheartening to see a 6-year-old child coming to us, and when we already have schemes to help them, but we cannot help them because they've already crossed the age bar. So you know, instead of, you know, complaining, see, there are difficulties, we understand, but then someday something has to be done on a positive note. Otherwise, finally, I am not suffering, the government is not suffering, it's the child who is finally suffering.
Even there are many child like this, not one.
Pragya, there are some questions in the chat box.
Yes, yes.
Okay. So Sanchita ma'am has asked how
Before that, reading,
as cost of ABR leads is high enough, it poses a challenge for implementation of universal hearing screening. Is there any government program to bear the cost? I think Biswas sir will know. I mean, there is a high-risk screening program in Guwahati Medical College, but under the program,
See, leads are not provided by the government. Whatever leads come, it comes with the equipments. After that, you know, you have to buy from your own pockets. I buy from my own pockets.
or
14,
I think
15,
maybe
100
if we
rupees.
wait for replacement, it will become a very long process. Maybe,
Yes.
sir. Yeah.
I buy from own pockets. Prakash, bhej do yaar, I have to pay.
Why, sir? Why, sir?
I do not know, you know, but to get the reimbursement is so difficult.
Difficult. Be sure you don't know this, the government bottleneck.
Getting reimbursement is very difficult,
Maybe I think what we've seen even in the EDIP program where the government had offered services and replacement of spares, on paper, they have given the information on paper, now it's there, but the actual realization
Yes,
of the thing,
correct.
and that again, that is happening at a very small scale. If we talk about the number of cochlear implanted children are much lesser compared to the number of children who needs to be screened, who needs to be tested, who or are even, diagnosed for hearing loss. So, and I think, I don't know, maybe just one advantage of having more professionals is that maybe we can then train up more individuals, even if they're not professionals, we can train them up to carry out certain things. And in that whole discussion, I think I again remembered way back, and again, if we are not able to compare ourselves with Kerala, we shouldn't be comparing with other countries. But I remember even in Sydney, when we had asked that how did it happen, it has been a long time for them that they have the universal hearing screening in place, many years. So they also mentioned that it is only when ENTs, social workers, pediatricians, neonatologists, psychologists, speech language pathologists, all of them formed a group, especially a special interest group for this. And then they approached the government again for years together, many times, multiple times. Only then finally it could happen. So I think that is one thing that has to happen maybe for any practical realization.
I think that is a practical point, I think.
Very
Special
practical.
special interest group by all the members.
Yes,
all
yes.
the speciality.
All have to do, because when training for the gynecologist, pediatrician you give, no one will come in NPPCD program.
Sir, my daughter, she's a pediatrician. She has passed pediatrics.
Yeah.
So I asked her, how do you manage your hearing screening in your college?
Yes.
Well, we'd send the patient, and we ask them to come in the evening to assess the patient. Sometimes they do come, they don't come. So how the program is going on? No program is going on. This is the attitude of the pediatrician.
Yes, that is I'm telling you.
It is my daughter. His
I
father
personally
is
know pediatricians' attitude are very bad.
His father is an audiologist. His father is an audiologist.
Vishwas, I am a little bold man. They only think of vaccination to earn money, and then nothing. They will not dedicate it to your hearing. I know. When I call for a meeting, given allowance also, no, I cannot spend time like this. They will tell like that. I face, therefore, it is not wrong, actually. Therefore, I have left after 3 years, calling the health commissioner, PP Verma. He told me, Dr. Fugani, go out. You cannot run this program. I request him to make me out. It's very difficult, these things.
Yes.
It's easy to tell, but the bottleneck you cannot break.
Yes,
suppose see, one instance, I'm not criticizing the government, Vishwas. Yes, you have started a CTBS center, neurology center. One patient came to my chamber. He has done a pacemaker. Then, a sister walked in to show me some year or something like that. Then I asked her, how they're running inside? All equipments are there. She told me, no, sir, equipments are coming. But the main problem is what? There is no water. There is no bathroom. Now the inside wall is breaking and bathrooms are start to constructing. Then see, in a high-tech center, you from outside is like a mall. Is it like this? It should be like this. It is not very bad. Because I am retired, therefore I can tell anything like that. But the sister told me, she is a I thought it is very good. I sent patient to some. This should not be like that actually. Then what will they give importance to our ear for the hearing child? Even to your cardiology and neurology and neurosurgery are learning like that. Is there any bypass surgery in cardiothoracic CTBS center in medical college? No, only Health City, GNRC, Nayan Hidalaya, they are doing that. This is very bad. Okay, I will not talk much because someone will feel bad also.
There is one more question.
Yes,
Pragya.
so Sanchita ma'am has asked, have you ever faced ear canal crust or wax posing hindrance in testing OEs and ABR? Definitely yes. OEs and both OEs and ABR can get affected with ear canal wax. And so when carrying out ABR, we always tend to first, if possible, we carry out the entire battery, starting with the impedance test, actually starting with viewing of the ear canal with otoscope. When we are not sure, we go for an impedance test to make sure there is no ear canal blockage or middle ear issue, and then only go for ABR. In the first step of screening for newborns, of course, we don't we don't come across wax, but yeah, the fluid in the ear canal, the intrauterus, the fluid in the ear canal definitely does, result in a refer result. And that is why I think most of the studies, they have also mentioned that rather than 24 hours, 48 hours or even 72 hours duration results in much lesser referral or false positives. Does that answer your question?
Yes, Pragya, thank you.
Okay, one clinical question, not administrative question. In a noisy environment like is PICU, NICU, what way you will prefer, DPOE or TOE?
DPOEs are slightly lesser sensitive to noise because it focuses more on the higher frequencies above 1.5, 1.4 kilohertz. However, again, an ambient noise level greater than 20-25 decibels is definitely going to affect the results both for DPOE or TEOE. But yes, DPOEs are slightly lesser sensitive to an ambient noise compared to TEOEs.
That
In
means
relation to
outside
that
DPO
question-
is better.
Sir?
Outside the screening, DPO is better, no?
Yeah, sir.
I try to perform DPO in a bit adult child, like 3 months, 4 months. That gives
Okay.
quite a good results actually.
Yes.
Even if the ambient noise is a bit high, it gives results.
The results in sense of good, positive, true positive.
Yeah, it gives results. Yeah.
Do you test the impedance if there is no pass OE? Not pass.
For newborn, we don't really carry out impedance that much, sir, because
difficult,
a lot of factors. I mean, reliability of impedance in newborns is a little difficult, and most of us, even for our center, we don't have an OE with, we don't have an impedance meter with, the high frequency probe tone, and using a low frequency, 226 or 660 hertz probe tone can result in wrong interpretations. It's difficult to obtain seals, a lot of things. So impedance is not much. So we don't really use.
One thing, that's one question I asked. Suppose cytomegalovirus, actually test is not much, that is costly also. And particularly suppose a case is postnatal cause, meningitis. But you may not detect in the earlier stage. Suppose you have done BERA also, or EBR, or in your OE also, you have missed. You also missed it, your hearing, but after that, he or she, the child, develop the effect of cytomegalovirus or the meningitis. Then you have to do a second or third scanning is needed, I think, no?
Yeah, definitely.
Marshall, the cytomegalovirus can develop hearing loss after 9 years also. Till 9 years,
Yes,
there is a
that is the
chance.
thing I'm asking.
You know why I'm telling. Few days back, maybe 1 month back, Dr. Nobo from Jorhat gave me a call that Vishwasa, this is one of the patient. This patient was normal earlier. Now the patient is showing progressive hearing loss. What shall we do? So I was reading a book, that time, and it was telling that CMB has progressive hearing loss. And let's say, I said, why don't you go for a CMB test? So that they immediately they went for CMB test, with IgG test. I think they have a talk with the microbiologist. They said, yeah, we can do IgG, and CMB was positive with this change.
Okay.
And CMB do give progressive late onset hearing loss.
Yes.
So if there is a chances of CMB, if you get a instinct that there is a CMB, this child should be followed up, till 10 years of age, 10, 12 years of age.
Thank you. Last one, again, clinical question. suppose this child is a CMP positive, pediatrician has a suspicion and they did the CMP positive, or then what is the final diagnosis? Is it a congenital hearing loss? It is a postnatal hearing loss.
It is a late onset hearing loss. Yeah?
Yeah.
It is a postnatal late onset hearing loss, you know.
It's not a congenital hearing loss, sir.
No. It's a late onset hearing loss because the child was normal.
That's why I'm telling you, sir. Most of the hearing loss we put in a diagnosis, in clinical diagnosis. When you go for newborn screening, what I have found when I get that this course of many people, they have written all these things as a congenital hearing loss. Congenital hearing loss with this postnatal infection is not a congenital. That's why I'm the simulation you to answer question actually.
Yeah, that's true.
Pragya, one last question.
Yes, sir.
Elijah genetics, because you see in COVID virus, the blood is sent to Kailani, Calcutta, for genomic sequencing to get the type of the COVID, because today it is the B2.375, the new virus has come, COVID. And like that of this genome sequencing is important of the neonatal screening.
So I think those kind of actions, genome sequencing and identification of gene loci has been carried out. I mean, in a lot of Western states, and I think in India also there have been lots of studies, and based on those they have identified also large number of gene loci which have been associated with hearing loss. Like many of the studies have also said that there are in many cases hearing loss is also attributed to a single gene mutation. So those kind of things have been carried out. Question is, should we be also referring for genome sequencing?
Yes.
We don't know, sir. Maybe
No, not available here. Only some center, Calcutta has got.
you have to send.
No, sir.
Very difficult.
It is also available now in Guwahati also, but it is very costly.
Yeah.
It is very costly. Issue is that the most of we have experience of few parents actually. They have requested us for the second pregnancy, second child actually. So, but since it's costly, but still we have no experience yet.
Yes,
This is available
for the second
because
child is very
our
important.
pediatrician is doing this genetic distinct test. Not that much of costly, 25 or 30, the range of 25 or 30,000. But we are thinking, but ICMR, most probably we have a discussion with ICMR also. But and they are also and they're ready. If you get more tests, then they can help us.
ICMR center main in Lahual, but they are also, I'm doubt genome sequencing is done.
No, not yet, sir.
Not yet done. Only from here.
Private Lalpet and all this they take. And Amitav sir is also started. Actually, every hearing loss child, if there is no perinatal or postnatal history, should go through genetic test.
And this time in West Bengal conference, they have a paper also on this. I was listening to that.
Oh,
there was a good paper. Yeah, good paper on genetic.
No, sir, Amitav sir already started the genetic test. Actually.
There was a paper also presented by the.
No paper, no.
Yeah, that was a good paper. They have been given first prize for that paper. You know, one SR has presented that. I was listening to that paper. You know, it was a very nice presentation and nice paper was that.
Yes, even Vishas, it is only available not in Calcutta also. It is Kailani only available. I think.
Yeah. It's Kailani. Test is done in Kailani.
Yes, there's the National Institute of Genetic Sequencing.
Yeah.
Not available here.
I think we'll wind up the meeting.
Yes. Discussion will never. For administrative to actually administrative discussions will be there. Then if some forum comes up, then I think the solution comes up. Otherwise, it will not come.
No, sir. Guideline is already there. So it is a kind of administrative.
The guideline, everyone knows.
Everyone knows what to do, and the new audiologists.
Implementation is the most important.
Sir,
how to implement.
Sir. Now the high time
guideline everyone knows.
So my only request is that now new
Even
audiologists are
the minister
coming.
also knows, commissioner also knows, principal secretary also knows, but they will not implement. I'm telling you.
No, sir, I think we can, because see the COVID, this one, how they are tackling it, because if you go to COVID vaccination and they will see the phone number and they know that you're due for the third one, like that.
No, that
So
is okay.
one day it will come, sir. The 80%
One day it will
successful.
We are positive. Yeah, we are very
Yes,
positive.
yes.
That
Sir,
is for last 15 years, I have seen nothing is coming.
1990.
No, sir. Just now, Mr. Sir has told, some Bani program is there. Something is going on, sir. So let
1991
us
to
be
2000.
hopeful.
Sir, we are hopeful. Many program is going.
Yes, sir.
Now the Guwahati Medical College is a very beautiful independent cochlear implant program under the leadership of Gautam Nayak sir. It's a
No,
great
that is
milestone.
okay.
No, sir. It is
Sir, let us
previously
be
so we have a
hopeful,
no
sir.
surgeon. We have only theory question of cochlear implant. 20
Yes,
marks.
sir.
So time is changing.
You have to increase the manpower. You have to increase the manpower. Otherwise, it will not cannot.
Almost
Alone
20
cannot do.
and 30 bestseller
Focus, sir.
from the Guwahati this audiology department actually.
Focus, sir.
Huh?
Focus, sir. We have an angry young man that Biswajit Gogoi, sir. One day you'll.
I am
tell
hopeful,
them.
madam. I am hopeful. If
Yes,
I alive, I am hopeful. Sure, I am very much
Yes,
hopeful.
sir, yes, you can do it. I know that you can do it. And
But he alone
Mr.
cannot
Sir,
do. He must be
No,
political
no, sir,
influence
that's
or
why.
something. A forum must be there.
No,
Otherwise, he
sir,
cannot do.
that's why we have taken up this one. So little step we'll take, and we are seeing.
There should be like-minded people. There should be academic interest. There should be devotion, patience.
No.
Everything should be there. Otherwise, you cannot do.
Mashallah, why can't we form a SIG group, special
Yes.
interest group on this hearing loss, taking
Okay.
pediatrician, ENT surgeons,
Yes,
audiologists, gynecologists, like-minded
Yes, sir.
person,
Yes,
like-minded
like-minded
Yes,
people.
yes.
Otherwise, you cannot do.
have a SIG group,
Yes.
Sir, correct, sir. Mr. Sir, you're correct.
And you should
Sir.
do a meeting and calling principal, director of medical education, every
sir.
principal secretary. You have to involve the administrative line.
Mr.
Yes,
Sir,
They will, if you
Yeah,
put the
yeah.
file, they will
Mr. Sir.
reject the file.
and after so many decades, we have a ISA, our own regional branch.
I am
Assam
hopeful.
branch. You are discussing. I have still remember from PG days. We have a need a ISA group, regional group, but still in 2022, we have a so we have a almost 30-40 very bright audiologists.
No, you have improved. You have done a cochlear implant center in Pratiksha, Vatindhani coming up, medical college improved. But if you go to some, see, Assam Medical College, is there anything good audiometer? Silchar Medical College, Tezpur Medical College, Jorat Medical College, Dipu. Yeah, I know MRI also. The patient goes to Dimapur.
Mana, person interest is also important,
No.
Yes, sir.
You cannot do like that.
No, sir, one fine day will come, sir. Let us wind up today.
Yes. Otherwise, I'll tell more.
Thank you so
Don't
much.
feel bad. I am telling from what I think.
Sir.
My vision
Sir,
is,
actually,
my vision may be
had,
not my mission, but I am just suggesting just.
No, sir, you had actually really faced trouble. That's why
No, there's
you're
a long
honest about
back.
it.
There's a
Yes,
long
sir.
back, 12 years
Yes,
back.
sir. You were right, sir.
Mashallah, tomorrow you have a
Thank you. My life to
competition, no?